All right, good evening, everyone. Hi. So I wanted to welcome all of you to this year's 2024 Women in Cardiology and Cardiovascular Team Symposium. I wanted to also thank our valuable industry partners for joining our event. The Nebraska ACC would not be able to meet its mission without all of your partnership. Here is our agenda for the evening. And then just a couple of housekeeping items I wanted to go over. Please keep your cell phones muted throughout the event. After the presentations, we'll have some time for questions. So feel free to ask our speakers at that point. The event is being recorded and will be uploaded to the event website at a later date. CME is available for tonight's event. And with that, I want to now introduce our chapter governor, Dr. Tunungutla.
Hello, good evening, everyone. It's my incredible honor to welcome each and every one of you to our inaugural Women in Cardiology and Cardiovascular Team Symposium. For those of you who don't know me, I'm Anu Tunungutla, interventional cardiologist at CHI Health, Nebraska Heart in Lincoln. I want to start by extending a heartfelt thanks to all of our sponsors for their invaluable support in bringing this fantastic event to life. A special thanks to all our board members, Drs. Mohammed, Tiwari, Goyal, Nikki, Shekhar, Tanya, and of course, Carmen. Thank you so much. Let's please show our appreciation with a big round of applause for all these wonderful people. Thank you. It is my privilege to kickstart this symposium by introducing our first speaker, Dr. Annabelle Volkman, who will enlighten us on the imperative of establishing women's heart centers. She is professor of medicine at Rush College of Medicine, founder and immediate past medical director of the Rush Heart Center for Women, McMullen Ibel, endowed chair for excellence in clinical cardiology, immediate past governor of Illinois chapter of ACC, past chair of the American Heart Association, Women in Cardiology. Please join me in welcoming Dr. Volkman. Thank you.
Thank you so much. Can you all see me? You couldn't have seen me without the step stool. But I want to thank you for inviting Anu. Thank you so much for inviting me. Carmen, thank you for inviting me. It's been such a pleasure getting to know Dr. Tunungutla as governors of state chapters of the American College of Cardiology. We, as women governors, we've gotten together and as a group, we really support each other. So it's been such a pleasure to get to know each other and do a lot of fun things together. We do the Midwest ACC Women in Cardiology, which I know they hosted here about 3 years ago or 4 years ago during the pandemic, the start of the pandemic. I was supposed to come here and I almost got to Omaha. I've always wanted to go to Omaha to see Warren Buffett's house, and today I was able to do that. Thank you for inviting me to speak about one of the topics that is very near and dear to my heart, why we need heart centers for women. I just want to tell you a story for why I started the Rush Heart Center for Women 21 years ago now. I had a patient. I'm an electrophysiologist by training, so I was doing a lot of EP procedures, catheter ablations, and I had a 40-year-old woman who came from an affluent community in Chicago, and she was having palpitations for about a year. And she was suffering from these palpitations and she wasn't getting any relief at all. And finally, her internist, she went to another internist who referred her to me right away. And I got an EKG, and she had WPW, which is very easy to diagnose with one EKG. And I said, didn't anyone diagnose you with this yet? And it's like, well, no one has ever done an EKG on me. And I thought that that was just ridiculous, that a woman who was complaining of palpitations never got an EKG. She would just kept getting told that she was just anxious, she was under stress, and she should just go home and take some Xanax. And that fueled my indignant feeling about how women are treated by doctors, not just cardiologists, but a lot of doctors. So when the American Heart Association came to me 24 years ago to start the campaign to increase awareness about heart disease in women, I jumped at the idea. I jumped at the opportunity to open the Heart Center for Women, to talk to women about heart disease and to educate not only the public, but the medical profession about heart disease in women. And so that was the impetus for my doing what I did 21 years ago. Thank you. So I just want to take you back. These are some statistics, some charts from circulation. And it shows that in the 1970s, there were more men in the blue line, dying of heart disease than women. But cardiovascular disease was the #1 killer of both men and women. But because there were more men dying of heart disease, they thought it was a man's disease. Men got ischemic heart disease earlier than women, and so they treated the men very aggressively, and they forgot about the women. And when statins came out, the men got statins, and they didn't know what to do with the women. And there was a nurses' health study that showed that hormone replacement therapy was associated with decreased cardiovascular mortality and events. So we made the wrong assumption that hormone replacement therapy was what we should be giving women with hypercholesterolemia. And I remember as an electrophysiologist, I didn't know how to treat hypercholesterolemia. So I went to my preventive cardiologist and I said, hey, Bob, what should I give this patient with high LDL? And he goes, oh, give her hormone replacement therapy. I'm like, okay. So I sent her to her gynecologist and they started treating her with hormone replacement therapy. And then we saw that, as you can see here, since 1984, there have been more women dying of heart disease than men. And in 2000, it peaked the gap between men and women. There were now 70,000 more women dying of heart disease than men. So the WHI study found that hormone replacement therapy actually increased cardiovascular events. And so we stopped giving hormone replacement therapy. So that's when we really started awareness about heart disease in women, and we started the Rush Heart Center for Women in 2003. I was one of 2 cardiologists who started the Rush Heart Center for Women. We had nurse practitioners, dietitians, psychologists, and nurses that helped us. Fast forward, this is 2024. These are my colleagues. We now have 10 female cardiologists who help us in the Rush Heart Center for Women, and we've done a lot of work. So what did we do as a result of this 70,000 more women dying of heart disease than men in 2000? The NIH and the AHA really got very aggressive with the awareness programs. We did a lot of studies studying women and heart disease. We stopped giving hormone replacement therapy and started giving statins. And we found that troponins were really very helpful. So that's when we started using cardiac troponins. And now with HS, high sensitivity cardiac troponins, it's even better. There's now a different cutoff for women versus men when it comes to high sensitivity troponins. And we are catching those small ischemic disease that we couldn't understand why women kept having angina and there was nothing wrong with them. Their stress test was negative. Their CATs didn't show any occlusive heart disease. So those women were told that there was nothing wrong with them. And we started Heart Centers for Women. As a result of that, this is what happened. We made a huge difference in cardiovascular disease mortality in women. So it worked. I'll show you later that unfortunately, there's been an increase in mortality again, partly due to the pandemic. And you can see here that now men again have more cardiovascular disease mortality than women. So we need to continue to work with our male and female patients. It's still the #1 killer of both women and men. You can see here the pandemic really increased the number of cardiovascular disease mortality. It's starting to go down again, but not significantly. So I'm going to tell you what we've done as in the Rush Heart Center for Women, and Dr. Madan was my fellow for several years, and she has really helped us understand heart disease in women. We've written a lot of papers, as I'll show you in some example. But when you build a heart center for women, you have to market it. You have to tell people that you are doing this, otherwise they won't know. I mean, even today, there's still some people at Rush that don't know that we have a Rush Heart Center for Women. So it's a commitment. When you build something, you're going to have to tell people about it. So we do community activities. We go to sorority book clubs. We go to churches. We do a lot of work outside of the hospital for the community to teach them about heart disease in women. And I know that some of you may be interested in starting a heart center for women. So I'm just going to give you some idea of how we've done our heart center for women. Because I'm in an academic center, part of our job is to write papers and to teach other people what we've done. So we created this statement white paper that was published in circulation along with my colleagues at the Heart Center for Women and my other colleagues from all over the country who also run heart centers for women. You may recognize some of these women, Dr. Lakshmi Mehta, Dr. Nidhi Agarwal, Dr. Sandra Lewis, Dr. Melissa Wood, and Dr. Jennifer Merez, and of course the Women in Cardiology chair, Dr. Gina Lundberg, who was the first author. Gina Lundberg was one of my fellows at Rush a long time ago, and she actually started a heart center for women in Atlanta before we started one. So she taught me how to start one. So the mentor is being taught by the mentee. So we all help each other out. The American Heart Association was a big part of the Rush Heart Center for Women. Every year we would have a luncheon. And we, of course, were very active with the Go Red for Women luncheon. And you may recognize this lady in red to Dr. Lynn Brown's right. Michelle Obama was the wife of the senator. He was, Barack Obama was just a senator back then. And so we were able to get Michelle to give a talk at the Go Red for Women. We were very fortunate that she helped us out. We also got involved with the Larry King Foundation, and we just went to lots of conferences to talk about heart disease in women, and we got a crowd to really help. Part of our job also is to teach residents and fellows. I don't know if you can see Dr. Madan was one of my fellows here. I take her out to ballets and dinners and wine and dine them so we could bribe them to learn about heart disease in women. Some of them were resistant. It's like, well, I went into cardiology to learn about men too. It's like, yeah, but don't forget the women. So we do educate our fellows about this. And then we wanted to get men to understand women and heart disease as well, because 90% of cardiologists are men, or about 85% of cardiologists are men. So it's not just going to be women taking care of these women. So we wanted to attract the men to come and understand heart disease in women. So Dr. Nanette Wenger, who is one of my mentors, is pictured there. We thought of doing a sex and gender influence on cardiovascular disease right before an AHA conference. And we had a great audience of men and women cardiologists and APPs to help us understand the differences, sex differences in men and women and cardiovascular disease. Part of our job also is to collaborate with people, and the people who are interested in studying women tended to be women. So we would go to these ACC leadership conferences in Washington, D.C., and we got a groundswell and we got a lot of collaboration. And when you go to these meetings, you talk about what you're doing and you talk about what you want to do. And so we really collaborated, wrote a lot of papers. And part of ACC's goal is to also increase women in leadership. And so this bottom picture is, it's not even a complete picture of all the ACC governors that was in 2024. So I'm very proud that Anu and I were colleagues as governors together. And we do a lot of things together. The Midwest ACC Women in Cardiology has been going on. This will be our 7th year. We did it, this was in Chicago, and we had a wonderful conference learning about heart disease in women, but not just learning about heart disease in women, but empowering women in cardiology so that they become leaders and they can do what they want to do. They can study what they want to do and really learn about heart disease in women if they want to. These are my colleagues from Rush. As I said, we just, we've had it now for 21 years. This was our 20th year anniversary that we celebrated at Rush Heart Center for Women. And as a result of our work with the AHA and the Go Red for Women, they gave us this award at the 20th anniversary legacy luncheon. So we were so proud that they recognized our work, and we've continued to collaborate with the American Heart Association. We've written 100 papers that we have published with other cardiologists, not just the Rush Heart Center for Women cardiologists, but all over the world. We write with other cardiologists from different countries as well. These are just some of the examples that we've done. We were asked to write about how we manage ischemic heart disease in women, because it's not as easy as heart disease in men. You know, heart disease in men, they have chest pain, you do a cath, they have an obstructive coronary artery disease, you stent it, you put them on statins and aspirin and Plavix, and they go home. With women, they have chest pain, God only knows what it is. It's not easy. So we created this algorithm to talk about ischemic heart disease. What is chest pain in women? So we divided it into acute versus chronic. And when they have acute chest pain, you have to look for obstructive coronary artery disease first and foremost, because that can kill them. That's the most life-threatening problem. So you have to rule that out. But in women, especially a young woman, and she's pregnant, the number 1, 2, and 3 diagnosis is SCAD, spontaneous coronary artery dissection. So if you are doing a cath, if some of you are nurses in the cath lab and your male cardiologist is not thinking about SCAD, please remind them, think about SCAD if it's a young woman who's pregnant. I mean, it's like a no-brainer, okay? Because it's easy to miss that SCAD. And then the hardest part about SCAD is how to treat it, because most interventionalists want to put stents in. And you should not put a stent in somebody who has a SCAD if they have flow. If they have blood flow, you leave them alone because it will heal and they will do fine. Because if you stent it, what happens is that dissection will propagate, and then you keep putting more and more stents. And now you have a full metal jacket where you have stents all throughout the LAD or the coronary artery disease. So SCAD, so you see what I mean by women? It's hard. It's not an easy solution. The other thing you have to think of is stress cardiomyopathy. An older woman, postmenopausal woman who has just undergone severe stress, think about stress cardiomyopathy. It can be deadly. Usually they have a benign course, but it can cause arrhythmias. So you can't just dismiss these people. They look just like a heart attack. They have SC elevation, but they have no obstructive coronary artery disease. And you just have to treat their cardiomyopathy, usually beta blockers, and they do fine. The ratio of women to men with stress cardiomyopathy is 9-to-1. So 90% of stress cardiomyopathy occurs in women, and a lot of them are postmenopausal. So think about that as a acute MI. And then there's the non-obstructive coronary artery disease, which is very complicated also. The easy things are spasm and myocardial bridge. Then there's coronary microvascular disease, which is probably the root of a lot of diseases in women. Women tend to have a lot of microvascular disease, and that's why they're so hard to treat. We don't have any guideline-directed medical therapy for microvascular disease yet. We are studying them very aggressively. There's a lot of studies that are happening right now. So hopefully in the next few years, we will be able to have some consensus on what we should be giving. And remember, women, if they have heart failure, they tend to have heart failure with preserved ejection fraction. And up until about a year ago, there was no guideline-directed medical therapy for these women. And it was only until the SGLT2Is came out that we now have treatment for these HFpEF, the heart failure with preserved ejection fraction. And I'm so grateful. But there are unique sex-specific risk factors for HFpEF, such as preeclampsia and central obesity. And a lot of these women tend to have atrial fibrillation, and the risk of death from atrial fibrillation in HFpEF is worse than atrial fibrillation in HFrEF. So we have to treat them very aggressively. This is the treatment for HFpEF that just came out in 2023. So until recently, we did not know what to do with these people. We would just give them diuretics, hopefully, just control their blood pressure, control their symptoms. But now we have data that SGLT2Is are the #1 treatment for patients with HFpEF. And the green means, yes, give it. There's data that it is helpful. Yellow means that there is good data, but you see there's a green border around that yellow recommendation. That means that we just need to get a little more data to make it green soon, but it probably will be green. But that is a good treatment. And then I don't know if you can see, but in terms of the cutoff for ejection fraction and the use of ARNIs, sacubitril valsartan, women will benefit at no matter what ejection fraction they have. For men, they don't benefit from ARNIs unless their ejection fraction is less than 50%. So there are sex differences in how we treat heart failure with preserved ejection fraction. This is the consensus statement that was published in JACC by Dr. Kittleson and Dr. Clyde Yancey. So another thing that we have been dealing with is the increasing maternal mortality in the United States, far exceeding that of all the industrialized countries. And unfortunately, this trend is not getting better. So we're still seeing an increase in maternal mortality, women who are pregnant who are dying from that pregnancy. So, and it tends to be very common, more in Black women. And also, since you are in Nebraska, we do see it in Native Americans, Alaskan Natives, and the Pacific Islanders and Hawaiian Natives. So those groups are the highest group for maternal mortality. So we need to be very aggressive in treating their hypertension and making sure they don't get preeclampsia, treat their diabetes, and prevent any cardiovascular events by treating the risk factors. And as you may know, it's not hemorrhage that is the #1 killer of these pregnant women. It is cardiovascular disease. And that's why we have become involved with the American College of Obstetrics and Gynecologists. And we, at the American Heart Association and the American College of Cardiology, have been working very closely with them to try to understand how we can decrease maternal mortality. We've written many papers. This is just one of the papers that we've written in JACC and in Circulation, and how we can prevent future cardiovascular disease, how we should be monitoring these women after they deliver. Another issue that women tend to to have problems with is breast cancer. Men tend to get prostate cancer, women tend to get breast cancer. So there are unfortunately interactions with breast cancer and cardiovascular disease. Women with cardiovascular disease could have complications from the chemotherapy or radiation therapy that they need. And women with cardiovascular disease can have worse outcomes if they undergo those treatments. And then after they get their breast cancer treated, we have to make sure we understand what the hormonal treatments do in cardiovascular disease, so that you could give selective estrogen receptor modulators or aromatase inhibitors. They have different problems in terms of cardiovascular problems. The SERMs, or the selective estrogen receptor modulators, tend to cause venous thromboembolism, whereas the aromatase inhibitors tend to increase cardiovascular deaths. So you can decrease cardiovascular deaths with SERMs, but you increase venous thromboembolism, but you can increase cardiovascular risk factors and mortality from giving them aromatase inhibitors. So we need to learn about all of this. Arrhythmias, that's been my focus. I've written a lot of papers on arrhythmias and women, and atrial fibrillation is one of my specialties. So, you know, they are undertreated with anticoagulation, with catheter ablation, and we need to be more aggressive with them. I know I'm probably need to stop, but I just want to show you that we created a toolkit in how to start a heart center for women. So if you're interested in how to start a heart center for women, the new ACC website, which is about to open, if it's open, is it open yet? They promised us that they will publish this in their website. We wrote this paper. We wrote this toolkit together. These are some of my colleagues who also run heart centers for women in the United States. You have to have a vision, you have to have a mission, and you have to have values to make it work. You can have different infrastructure. You can be in private practice, you can have an academic practice, and you can just start a prevention in underserved communities. If you're a nurse practitioner, if you're an internist, you can start a heart center for women to try to prevent the risk factors or treat the risk factors, and you could be very successful in helping decrease cardiovascular deaths in women. You could have different focus in your different center. If you're a preventive cardiologist, do that. If you're a general cardiologist, you just refer to a lot of your colleagues for EP or for structural or intervention. You could have a multidisciplinary team. We have a multidisciplinary team. We have different we have heart failure doctors, we have EP doctors, and the whole gamut of multidiscipline. And we work with the maternal fetal obstetricians to decrease mortality in our pregnant patients. Or you could have a center that just focuses on MINOCA or INOCA, that's myocardial infarction with non-obstructive coronary artery disease. You could have a cardio OB program, or if you're a gynecologist or a doctor or a cardiologist who likes to take care of old people, you can have menopause related issue as your focus as well. And we all should be advocating. We as governors are supposed to go to Washington, DC to advocate for our patients, and we should all be doing that. If you're in private practice, you can join registries as part of research. You can also do, we do a lot of behavioral research interventions as well. We were just looking, I work with some of our nurse PhDs at Rush, and we just did a study on whether doing cognitive games on the computer versus physical activity, or doing both versus their usual care can decrease cognitive dysfunction. So we're just looking at that data now. We got a $4 million NIH grant to do that. You can also just concentrate on quality, make sure that you have a quality initiative team that can look at the outcomes of your patients. If you have interesting case reports, I was just talking to Dr. Madan, who's, she's in private practice now, but she was very academic when she was at Rush, and she still continues to work with other people. But case reports is a great way to showcase some of the interesting cases. So if you have an interesting case, please tell us about that case, because we can all learn from these that's how we figured out Minoka is patients just kept coming with chest pain that didn't have obstructive coronary artery disease, and now it's a big field of study in women and heart disease. You can also just do review papers. We did a lot of review papers because we don't always have time to do a lot of investigational research. So in our leisure time, which is nothing, we would just read papers and summarize them, because there's a lot of papers out there that have a lot of different data, and to consolidate it all is very helpful, so we can all learn from that. One of the big things that you need also is financial support from your practice. When we started the Heart Center for Women, we had to have a buy-in from the dean, from the president of the medical center, from our the chair of medicine, the chief of cardiology, so that they would support this. And they were very supportive. They knew it was a way to help women and to get patients through the door, to your door, because if they hear about it, they will come. As they said, if you build it, they will come. So you need also to get, if you can get philanthropy support. I'm so happy I just tell you that just yesterday or Monday, I was talking to one of my friends who has, she's a young woman who just had bypass surgery 10 years ago, and she's now in her 60s, and she's a very rare disease, but she's very wealthy. And she said, Annabelle, I just want to help you. I just want to help you with what you're doing. So she's giving me $100,000 to have an endowed professor lecture. So we will invite a prominent female leader who will teach us about heart disease in women. So these are some of the things that we're doing to increase awareness about heart disease in women. And then, of course, there's the grants, which is hard to do, but if you're a research guru, then that's the way to go. So just to summarize, why do we need heart centers for women? We need them because women, compared to men, have different manifestations of cardiovascular disease. There are sex-specific differences that need to be studied, such as pregnancy-related disease or menopause-related or breast cancer. There are also certain diseases that have a predominance in women, such as heart failure with preserved ejection fraction or non-obstructive coronary artery disease. And these are the ones that we didn't know how to treat. So this is why we need to do the work that we're doing. And of course, there's always the socioeconomic determinants of health that can cause women are poorer than men. And that's just a fact. We don't have we have worse access to healthcare. We have less wealth. And so we don't have as good insurance. And so we have these socioeconomic problems that can cause worse cardiovascular outcomes in women. And we just want to make women happy and healthy. Thank you.
Thank you. I have a quick question. Great presentations. Both of you were so wonderful. So Dr. Bowman,
We have members here from different organizations. We don't have a dedicated Women's Heart Center in Nebraska. But I'm very inspired by the work you've done, and I think it would be great for us to do something. And, the idea of,
I will help you.
that's great, that's great. And sometimes I'm like, this is a daunting task, like in terms of finances and stuff. Are there steps we can take, like small steps to at least get started if we're not gonna open up the whole women's center? What are some ideas where we can start introducing this concept, maybe?
Absolutely, yeah. So we had the same issues. There was no money. And it was just an idea 21 years ago. And my nurse practitioner said, we should have a center. We should have a beautiful space. Like, no, that costs money. And Rush is very tight with money. If you don't produce, they'll shut you down. So I knew that. I learned from other people who've started centers and they get shut down. So I did not want to be in that cutting board. I wanted to continue to prosper. So what we did was we had the Heart Center Forum within our practice so that no one could tease out how much money we're spending versus the whole practice. So within our practice, we just called ourselves the Rush Heart Center for Women. And we concentrated on women. We advertised that we are specializing in the care of women, and the women came. I was telling Nydia, a lot of my patients are nurses because they care about their cardiovascular health. They want the best doctors. And so they look for who's the best doctor to treat them. And, they see the Rush Heart Center for Women.
Do you have a dietitian, a psychologist that will support like from the beginning?
So it was the psychologist was part of our practice. They were paying for her salary. She was seeing patients. Unfortunately, she was lured by a competitor because she was so good. So we lost her, but we continued to work with our psychologist. We have a social worker that works within our practice. And so we don't have to pay any extra. The nutritionist piece was very interesting because we wanted to have nutrition as part of and I'm sure they don't counsel the patients the same way that you do, but they do the Mediterranean diet. And the AHA, we actually created a Mediterranean diet screener that has now been supported by AHA to be the screener for all patients. So we're very proud of that. We published a paper on that because it was so important to us that nutrition was part of the Heart Center for Women. So what I noticed is that if a patient doesn't have diabetes or renal disease, their insurance wouldn't pay for it. And so the patients who didn't have diabetes or kidney disease, they would have to pay either $80 or however, much. Before it was $50, now it's $80 for nutritional counseling. So what I did was I had a very grateful patient, a male patient who just supported me. He said, Annabelle, what can I do to help you? And I said, well, I need to pay for a nutritionist so that we don't have to charge our patients for the nutritional counseling. And he goes, how much do you need? And, we have wealthy people in Chicago, as you do in Omaha. And he would give me $25,000 a year for free nutritional counseling for all of our patients, whether they had any renal disease or diabetes. So we didn't ever charge for them. So it was free nutritional counseling. And a lot of my patients took advantage of it. So you don't have to have that. You can work with your nutritionist in your hospital. You're at Creighton, you can talk to the nutritionist. If they're very interested, you can, negotiate with them to pay for a little bit of their salary. Because we would only see patients, the nutritionist would see patients half a day a week, and that was enough.
Can you tell the audience one more time where they can find the toolkit for?
So it should be in the ACC website. They promised me that when they rebooted the ACC website, they were rehashing it, the whole website, that they would publish that. But if it's not there and you can't find it, please email me. Ask Carmen for my email, and I'm happy to send it out to you. It's a very comprehensive toolkit with business plans. With Tanya Singh helped us with the business plan. You don't have to have a lot of money. You don't have to have any money to start a heart center for women. You just learn about the disease that affect women. Make sure that you learn about heart disease in women and make sure you know how to treat them. And that's what they want. They don't want a big fancy place. They want to see that you understand their problem and that you know how to treat them, and you know, at least tell them, you know, what you know about it. And if you don't know, then you just state that, and we can enroll them in studies. Any other questions?
All right, well, everyone, thank you so much. We've reached the end of our event. I wanted to thank you all for your participation and hope that you've enjoyed your time with us and that you've learned something today. I also wanted to thank our speakers once again for sharing their time and expertise and coming and spending their evening with us. And as well as thanking our industry partners for their participation in our event as well. And with that, I'll let you guys enjoy the rest of your evening. Thank you.